It's recording.
Hello to everyone. It's my pleasure to welcome all the participants and the speakers today. The simple talks by Dr. Sabrin. And nowadays, you know, it's growing more and more, and we are touching many different topics. And first of all, I would like to introduce Dr. Parisa Fouroughiasl, who is currently working as oral maxillofacial surgeon in the United States of America. We would like to know from you what's your opinion regarding such webinars, and especially as oral maxillofacial surgeon regarding the traumatology itself. So welcome, Dr. Parisa.
Hi, thank you so much. Hi, everybody. Good morning and good evening. And it's my pleasure you invite me in that conference. Actually, it's great we share our experiences together to know and improve our knowledge during this pandemic time, and use these disaster times to share our experiences in these important topics, which is the most common form of trauma is a facial fracture. And I want to thank Dr. Saponaro. And it is great to know you, and you share your practice and knowledge with us. It's great, and
thank you very much. Thank you very much for having me here, and thank you, Sabrin. And
Dr. Saponaro, so I would like to introduce you. So currently, Dr. Gianmarco Saponaro is working as a researcher and consultant in Catholic University in Rome, and he's oral maxillofacial surgeon. I would like also to highlight that behind this scene, we are also good colleagues and friends. We had a training together in Austria, in the biggest hospital there. It was a good chance to, you know, to know each other. And I would like to give a floor to Dr. Gianmarco.
Hello, everybody, and thank you for inviting me. Thank you, Parisa, for coming all the way from the US, even if just virtually. And thank you for for highlighting our also personal stories. There are some pictures around there I saw. And so today I would like to bring my experience, actually the experience of our center regarding the facial traumas, and I would like to give you like a short introduction about fascial traumatology in general. Then I will focus more on the mid phase. I know that many of you can actually do maxillofacial surgery through dentistry. So even if it's a dental school, I think it's really important for you all to know something about this important topic, even for those who won't become maxillofacial surgeon. Is that like this in for you, Parisa? You can do maxillofacial surgery through dentistry. Well, for us it's the other way, so we through medical school. Let me just share my screen. Can you see it? Yes?
Yes,
okay.
Yes.
All right. So let me first introduce you my institution. So my institution is the Catholic University School, which is linked to the Policlinico Agostino Gemelli Foundation, which is one of the 3 major hospitals in the city of Rome. It lies in the northern part of the city, and it's a major hub for traumas, for not only for the city itself, but for the whole northern part of Lazio, which is the region Rome is also capital. So it's the capital of Italy and a capital of Lazio, which accounts for probably something like 3 million people. So it serves 3 million people. It's a very big hospital with a very big department of emergency and first aid. So everything you see behind here is the department of the emergency. So it's pretty big. And there are different traumas that can access our center. And now we go more towards the topic of this lecture, so the general principle and management of fascial fracture, and then we'll focus on the middle third, as I said before. Before we go to and talk about the fractures, it's better to understand what is multiple trauma patients, because many fascial traumas are actually in a framework of different problems, so different trauma problems. So we have to make a first big difference between an emergency and an urgency. So where do fascial fracture fall in? An emergency is a situation that carries an immediate risk of loss of vital function or life-threatening, potentially life-threatening situation, and it usually has to be immediately addressed. While an urgency does not involve the need of immediate treatment itself, but it can be prone to worsenings and actually retains a certain grade of priority. So an urgency is not an emergency, but it can become an emergency. And most of fascial fracture actually fall in this second category. Not all of them, not all the time, but 95% of the times is an urgency. So it retains a priority, but it doesn't have to be assessed right away. Usually an emergency is a lesion that prevents or alters breathing or blood circulation, also in the sense of a hemorrhage, loss of blood. And generally all multiple traumas with loss of consciousness are treated and considered emergencies because of the risk of breathing problem. Usually fascial fracture, as long as we're not talking about some specific or particular cases, do not fall into this three category. But then we'll see when this happens. These emergencies usually need an immediate on-site treatment or right admission of the hospital in order to manage the airway patency or the bleeding control. The airway patency, when we are talking about maxillofacial district, can be differentiated into two big categories: intraoral causes or extraoral causes. The intraoral causes are those that mostly they're mostly in the maxillofacial fields. So the presence of blood or clots of blood inside the oral cavity, the presence of gastric content with a reflux from the stomach, the presence of foreign body, more specifically and more frequently are dental elements or parts of whole dental prosthesis which can be displaced, hematomas or the oral cavity, which can actually grow in volume and start occupying space. The tongue retropulsion is not very often found, but it can be very, very problematic. And this specific fracture can itself be a reason of emergency, which is the bilateral parasymphyseal fracture of the mandible, which is basically there is a loss of stability of the frontal part of the mandibula where all the muscles are attached. And this can actually push the fragment along with the tongue backwards, closing the upper airways. Extraoral causes, as I said before, are the loss of consciousness and direct traumas on the laryngeal cartilage. And of course, there are several other problems, but they do not fall in the maxillofacial field directly. The foreign body removals is usually carried out simply with the use of hands or with the use of McGill forceps, which you can see here in the right part of the screen. The tongue retropulsion is usually caused either by bilateral parasymphyseal fracture or sometimes by simple loss of muscular tone. Their management is usually done by passing a stitch in the anterior aspect of the tongue and applying a tension in order to open the upper airways, as you can see here. So the base of the tongue go and collapse on the pharynx and closes the upper airways adductus. With this maneuver, we can just pull it out and open the airways. Another emergency procedure which can be required to a maxillofacial surgeon is the emergency tracheotomy. The emergency tracheotomy is not a proper surgical operation, it's more of a procedure, and it usually consists in a small cut which is made on the overlying skin at the junction between the laryngeal cartilage and the cricoid cartilage on this little area. Can you see the arrow, by the way? Can you see my mouse?
Yes.
Okay.
Yes.
So the incision is usually, it's done, not usually, it has to be done here in this little area, which is the thyrocricoid membrane. Why in this area? Because this area is a relatively safe area because there are no major structures, there are no major vessels, it's under the laryngeal planum, so it's under the vocal cords, and so making a cut here minimizes the risk of bleeding or other kind of damage. The other way of accessing and opening up the airways is the tracheostomy. Tracheostomy, it's a proper surgical procedure. It's rarely carried out in an emergency environment. It's more of semi-elective procedure, and it's usually used and made for patients who require prolonged intubation. So it's more of a procedure for patients who are hospitalized for a long time. And it's made through, depends on the technique, but this is the one we use. So it's made through a cut on the skin of approximately 5 to 6 centimeter length, performed 2 centimeters above the jugulum. And the trachea is accessed by separating the infrahyoid muscles along their junction on the linea alba, and until we get to the thyroid. The thyroid can be cut into 2 lobes along the isthmus, or it can be attracted cranially or caudally. In order to free the trachea, perform a hole or any kind of cut, we usually perform a U cut, opening on the caudal aspect, and a cannula is inserted. The canulas can be of usually 2 types: the cuffed cannula or the uncuffed cannula. The cuffed cannula has this little balloon connected to a reservoir that allows us to put air in it. These will separate the oral cavity, so the oral cavity and the nasal cavity, from the lower part of the airways. And this is usually done when there is risk or of leaking of any kind of fluid, mostly blood, from the overlying cavities to the lungs. While where it's just a respiratory issue, uncuffed cannula is more than enough. Let's go to see what's the second problem is about. So about circulation and bleeding management. Mostly in traumas, the biggest problem is bleeding, and bleeding in the maxillofacial field can occur as well into 2 possible ways: intraoral or extraoral. More commonly is intraoral, and the intraoral bleeding is usually happens when there are tears in the oral mucosa or dental avulsion, or rims of the fracture are exposed in the mouth, especially when it comes to mandibular fractures. Sometimes there can be tears in vessels inside the oral cavity, and for example, the damage to the fascial artery is not often found, but it can be found relatively often, and it can be a very problematic issue. And in that case, the fracture will become an emergency. Extraoral causes are usually consisting in muscular or cutaneous tears of vessel tears outside the oral cavity. And a very, very common extraoral cause of bleeding is the epistaxis. And now we'll see how to manage it. Before we go and we talk about procedures, I would like to remind you about the facial circulation. The facial circulation is mostly charged on the branches of the external carotid artery. These are the branches. It's not very important to know. The most important ones are the lingual artery and the fascial artery. The fascial artery passes approximately 2 centimeters anteriorly from the mandibular angle. There is a notch, which is the antegonal notch, and in that notch pass the fascial artery along with the fascial vein. And those can be really problematic. And it's an accident that happens quite often. Another important branch that we have to keep in our mind is the internal maxillary artery. Why do I say that? Because it's a very, very hard to manage bleeding, because it lies very posteriorly. There are a lot of structures in front of it, and it's very hard to access through a surgical operation. And then we'll see what we have to do in those cases. As I said before, the most common cause of bleeding is the epistaxis, so bleeding from the nose. What do? We do the nasal packing. Packing is one of the most effective and first-line treatment for hemorrhage in the maxillofacial district. Regarding if we are talking about nasal packing or oral packing can also be performed similarly in a similar way. So by basically packing gauzes inside the cavity, increasing the volume and the pressure from the cavity outward, trying to stop the bleeding simply by pressure. And for the anterior nasal packing, in former time, this was the way. So literally packing a gauze inside the nasal cavity. Nowadays, we rely mostly on Merocel. Merocel, it's a sponge-like material which absorbs whatever fluid comes in contact with. Can be saline, can be the blood itself, and increases in volume, and it applies the pressure we are looking for. We can pack 1 or 2 Merocel. It depends on how the bleeding is being managed. Sometimes anterior nasal packing is not enough, because the tears and the region of bleeding, it's posterior, and as you can see, this kind of technique doesn't come posteriorly. So in those cases, we apply a posterior nasal packing. This is also like a former time picture. It used to be done like this with gauzes again, with a gauzes passing through the mouth, attached to a lace that it comes through the nostrils, and by pulling the lace, the gauze would come in the posterior nasal aspect of the nasal cavity. Now we mostly rely on balloons. It's called Bivona balloon, and it works the same way. So we introduce the sound deeply in the nasal cavity, we inflate the balloon, and we pull it up, and packing in the posterior nasal aspect of the nasal cavity. I'm sorry, this is in Italian, but I couldn't find it in English, and I will explain you what is it about. So if you remember, I just said that the most threatening problem is the maxillary, the bleeding from the internal maxillary artery. What do we do surgically? Nowadays, with the development of surgical radiology, and in a very big hospital like ours, this can actually be managed by a surgical radiologist by intravasal management. But if there is no such a kind of professional in your hospital, the most effective way is to block completely the first vase, of which the internal maxillary artery is a branch, which is the external carotid. And the external carotid ligation implies accessing the content of the neck arriving on the external carotid and ligating it. How do we recognize the external carotid from the internal carotid? Does anyone have a clue? Not you, Sabrin, about your students. I know you do.
I was going to open a mic. I think you closed your mic, doctor. I think let's keep the questions for the end. Dr. Saponaro.
Okay, no, I'm on mute. Yeah,
right.
I must have done something wrong. Okay, yeah. So the way we can recognize, make a difference between the two arteries is that the internal artery has no branches. The internal carotid artery has no branches, while the external carotid artery has many branches. And we'll see them right when we open the neck. Now we finally finish this boring introduction part, and we go right on a craniofacial traumatology. Craniofacial traumatology has a different incidence depending on the age. As you can see from the chart, the highest percentage of second and third decades of life. But nowadays, I was reading a few papers, and it's actually, I think everybody experienced that this is moving onwards with the improvement of quality of life, of the general life expectancy. Even there is a higher increase in the incidence even after these 2 decades, and even after the 50 years old of age. Why this is happening? Because our kind of fracture, like most of the fractures, are strictly linked with activity, any kind of activity. So like years ago, people after 60 years old, they just stay in the house in retirement and everything. Nowadays, it's not like this anymore. So yeah, it's still the most high incidence part of our lives between the 20s and the 30s, but it's moving up. While under during childhood or adolescence, the incidence is not that high, especially as you can see under the 6 years of age, the incidence is very low, it's less than 1%. And then we'll see why this happens. Another thing that has to be said is that the incidence move from the upper district to the lower district with the increase of the age, meaning that in the younger the patient is, the more is likely to have an injury in the upper part of the fascial skeleton. For example, children under 6 years of age, it's not that they don't have traumas, it's that the traumas mostly occur on the narrow cranium. And going down, it moves from the narrow cranium to the splanchno-cranium, so to the fascial bones. And now we'll see why this is happening. It's just a matter of development. The children under 6 years of age, especially the children under the 3 years of age, they have this ratio between narrow cranium and splanchno-cranium. So the splanchno-cranium is very small compared to the narrow cranium. It's actually 1/3. And as you can see, it's not situated in front of the narrow cranium, it's just under the narrow cranium. What happens with the growth is that the narrow cranium, the narrow cranium stops growing, while the maxillofacial district keeps going and growing until depending on female or males, but it grows until 18 years old, 20 years old of age, depending on the district, because it's not uniform. And what happens in an adult is that the maxillofacial complex goes in front of the narrow cranium. And this is very important, and we'll see why this is important. About the causes, as you can see, the highest peak is street traumas, followed by accidental falls, sport traumas, and assault. Accidental work do not cover a very big amount of percentage. The ratio is, but this is also changing. It used to be more in favor of males, so there were more males who were prone to receive a facial trauma than females. And this happens because, as I said before, the fascial fractures are activity linked, and the males historically used to carry out a more, let's say, aggressive state of way of living, more sport, or more prone to have assaults and so on. But now this is changing because the world is changing, and this is also changing. So why I said it is important that the maxillofacial complex goes in front of the neurocranium? Because the maxillofacial complex holds a very, very important role, which is being a defense system of the important structure of our craniofacial complex, which are basically two: the eyes, so the vision, and the brain. So this whole complex is made up by nature in order to protect this important function. And it's made up of several different systems that work together in order to dissipate the energy that is. And these subsystems are the sutural system, so the bone sutures that help dissipating energy, the paranasal sinuses, the resistant pillars of the upper maxilla, about traumas of the maxilla, which are areas of increased resistancy that will help to dissipate energy by basically promoting a horizontal fracture and not a vertical fracture. The bone morphology itself, because the fascial bones are mostly convex, and this would also help to dissipate energy. The dental velar system, especially the occlusion, it's very important, and the masticatory muscles. So what do we search for when we suspect there is a fascial fracture? As everything in the medical field, the clinical diagnosis is made up of different steps: the extraoral inspection and intraoral inspection in our case, and the palpation. The fourth one would be auscultation, but there is no need of it in our case. As extraoral inspection, what do we look for? We look for fascial asymmetries, soft tissues alteration, hematomas, the presence of epistaxis, the presence of diplopia, so the double vision. The patient says that we do a proof, then I will explain you what we do, and the patient tells us that is seeing two fingers. So we basically show the patient our finger, and when we move it right to left and up to down, and the patient has to follow it just with their eyes without moving the head. And in a very specific situation that will be shown later on, the patient could tell us that he sees two fingers. At intraoral inspection, what do we look for? We look for occlusion relationship alteration, but also for occlusal plane alteration, because in the case of a mandibular fracture, for example, the two fragments could move, so the occlusal plane could change. What kind of occlusal alteration? All of them. The presence of reverse bite, open bite, of cross bite. Of course, it is very important to ask the patient if that malocclusion was present before the traumas. Sometimes it happens that we go to the OR and we try to fit the occlusion, and you basically find a malocclusion. Sometimes that's the previous occlusion of the patient. So what's important is not to give a good occlusion, it's just to give the patient the occlusion that he had before the trauma. At the palpation, what we can find is bone discontinuity or the mobility of bones. I would add another thing, which is not here in the list, which is the crepitus. Sometimes we push on the patient's skin, especially in areas which are swollen, and we feel a crepitus with our fingers. That's because air has come through the subcutaneous tissues, and it's basically a subcutaneous emphysema. That's definitely a sign of fracture. And then we go to the very important radiological diagnosis. Nowadays, no diagnosis is made without a radiological diagnosis. We mostly rely on a CT scan or MRI, but MRI have a limited function, then I will show you later, and Panorex. Personally, in our center, we don't have a Panorex in the emergency department, so it's just CT scan. But I felt it would have been important to report what the traditional radiology has to tell us, because not a hospital might have a CT scan, or so sometimes we still have to rely on plain radiograph. And there are 4 main projection of the traditional plain radiograph, which is the occipital buccal, the frontal, the lateral, these are like telecraniums, and the attenuated axial. The attenuated axial just have one function, and we will see when we talk about zygomatic fractures. About the treatment, there are different treatment options. Of course, it depends on the kind of fracture, it depends on the localization, it depends on the grade of comminution, displacement. Many aspects have to be considered when talking about treatment. But generally speaking, these are the options. So the surgical treatment with internal fixation, this is the gold standard for most of the fractures. Surgical with no fixation, it has some limited but important indication. We have surgical with fixation, but not internal fixation. There are some kind of indirect fixation, which is like the arch bars that you can see here in the picture, or sometimes we can also use external fixation. And then we have the non-surgical options. Some fractures are simply not surgical, because there is low displacement, because there is no risk for the loss of function. So sometimes we just don't treat them. What about the type of fixation? There are 2 big categories about when we come about fixations. Of course, I'm talking about the most traditional way of fixation, which is the titanium fixation. And we could divide the kind of fixation into 2 big groups: load bearing and load sharing. What are we talking about? What's this load? The load is the pressure, is the work that the bone have to do in their everyday life, and it has to be loaded by the plate or shared with the plate, just like this in this picture. So as you can see, the arrows represent the load. And the first picture, the upper part, is a load bearing. So it means that the bone bear no load at all. So the whole load is borne by the plate itself. While the most frequent one is the load sharing. So the load is shared both by the bone and the plate. So it's divided into the 2. Of course, these 2 kinds of fixation have different indication. We're talking about the the mid phase, the load sharing, the load bearing basically have almost no role. And in the mid phase, we usually look for load sharing plates. And these are the load sharing. Load sharing plates are plates made in titanium, and they can go from 1 millimeter, so very, very small, to 2 millimeters. And they usually have no lock screw. What's a lock screw? Again, to the picture, as you can see, these screws, they have some more screw in the head. This means that these screws will lock on the plate. Lock on the plate, and this basically will work through it is said external fixator internalized, because they have to bear the whole load. While for mini plates, this doesn't happen. So it's usually non-locking screws. A load bearing, it's mostly used for just one indication. So it's very comminuted fractures of the mandible. So those fractures when on a bone which has to bear a lot of load, but it's too fragile to bear it. So what do? We put a load-bearing plate. So the plate will do the work in the place of the bone, leaving the time to the bone to heal properly. Another option it's a very new option, are the resorbable plates. There are several brands and several kind of resorbable plates, mostly done with two material, the hydroxyapatite or the polylactic acid. The one you see in the picture, actually, I would say this is a net picture, and there are of hydroxyapatite. Some others are just made with polylactic acid. Others are a mix of the two. What we're using in our department are the one that you see in the right part of the picture. They are made with a mixture of hydroxyapatite and polylactic acid. What's the difference? The polylactic acid wears off very fast, and it's very good, for example, for kids, but it has a very low capacity of molding the plate. While hydroxyapatite retains a stronger force, and it's easier to mold, so we can do all the shapes we want, but it stays for longer, and it can also break because it's more rigid. It can break more easily compared to polylactic acid. And also the polylactic acid is associated with an higher risk of any kind of reaction, irritation for the way it gets reabsorbed. So basically the hydroxyapatite becomes bone. The polylactic acid is reabsorbed by the body. So in order for it to be reabsorbed, it induces an inflammatory reaction, and that's why they can be more uncomfortable. Now we go more in the specific field, and we talk about the orbital zygomatic fracture. So we have everything we need now to proceed and understand the principles more properly. Before we start, a very, very quick review of anatomy. The orbital cavity is a cone-shaped, approximately, cavity, which is made up by seven different bones, with basically, we say 4 walls. So the upper wall, the lower wall or pavement, lateral and medial wall. There are 2 walls that are more fragile than other, and are the orbital bone, orbital is the orbital floor and the medial wall. These 2, they often break. The other 2 is less common. Inside the orbital cavity, there are several different structures that pass through and that we have to keep in our mind that actually exist in order to understand what damage can a fracture do. I won't go in a deep, but there are just a second. Okay, I thought you were pinged up, Sabrin, sorry, because I couldn't see you anymore. And there are several kinds of structure. There are nervous structures. Most of them are motor nerves that are they have the aim of unnerving the extrinsic eye muscles. There are those muscles that implement the move of the eye, and we'll see further. And there are vessels. The most important ones are the ophthalmic vessels, vein and artery. And then we have, of course, the optic nerve. And then we have some branches of the trigeminal nerve. So sensitive nerves, frontal nerves and infraorbital nerve. And then we'll see why it is important to keep in our mind that these structures actually pass through the orbit. As I said before, there are nerves that innerve muscles. Which are these muscles? The extrinsic muscle of the eye are basically 6 muscle plus 1, as I say. So basically 7, but the levator